Yeah. Good morning, good afternoon, everyone. Welcome to the Global One Health Summer Institute. So this is sponsored by The Ohio State University. We're very fortunate today to have our infectious disease lecture block. We will be beginning with Dr. Zainab El-Boudagli. She is a clinical associate professor of internal medicine at The Ohio State University College of Medicine in the infectious disease division. She will be presenting on approaches to neutropenic fever and the infection risk in cancer patients. We will be followed by Dr. Natalie Nielsen. She is an HIV specialty practice pharmacist, also at the OSU. And then lastly, she will be presenting on antiretroviral therapy. And lastly, we will close with Dr. Maddie Sabani, who is Associate Professor of the Ohio State University College of Medicine Infectious Disease, also the Program Director for our fellowship program. He will be presenting on endocarditis. I am very happy to also welcome Dr. Shu-Hua, who is my co-moderator today. Dr. Shu-Hua, did you want to say anything?
Hello everyone. I think we can start the presentation and if there is any question and we'll discuss in the middle or after end, whichever is convenient.
Yes. Thank you, Dr. Shu-Hua will help to close out the session. So we do have a Q&A box, so please feel free to type in your questions and then the speakers will try to answer them after their lectures. And if we're not able to get to any, then we will also send them out. So again, the session is being recorded and we will share the slides as well as the recording link with you after the entire Summer Institute session is over. So over to you, Dr. Zainab.
Okay, thank you for the introduction. I'm happy to be here. Do you see my slides?
Yes.
Okay, so today I will be talking about three topics. We'll start with key principles in diagnosing infections in cancer patients. We'll go over risk stratification among different types of cancer. Then we'll move to talk about infectious threats associated with some of the new immunomodulatory agents. And then we'll end with talking about neutropenic fever. We'll take to the historic view of management, antimicrobial prophylaxis, inpatient and outpatient management. I always like to start by saying that cancer patients are at risk for the same infections that the regenerative population are at risk for. So common infections are common, although it's very tempting sometimes to think about the zebras and also the fascinating diagnostic dilemmas with infections. It's important to individualize assessment of these patients and understanding the whole immune status of the patient, which put them at risk for particular infections. This occurs when we understand their immune dysfunctions, their lymphocytic, neutrophilic, their NK cells, and how they are affected by underlying cancer. And because of their impaired immune system, sometimes the typical case presentations and disease formation is not similar to what we read in the textbook. So we need to be vigilant for the early signs of infections in these patients, as it can carry a high morbidity and mortality. And sometimes these patients may harbor a bad infection, like invasive mold infection, and they will look completely stable. So lack of major signs of sepsis does not eliminate the risk for infection in these patients. And we need to also understand the impact of good diagnosis by utilizing the microbiological tools that we have in these patients and what are the falses of false positive and negative in this population. With that, I will shed some light on the factors contributing to infection in these cancer patients. So it's an interplay of four main categories. First, starting with the patient himself, factors such as having underlying comorbidities like diabetes, age factors, their genetic susceptibility to infection, all play into the risk of infection. Second, what the type of cancer do they have? Is it solid tumor, or is it heme malignancy that actually impact their immune system to start with? And what's the stage of cancer in these patients, which will impact their prognosis overall? Third, the environment they live in, and that predisposed to acquiring new infections or reactivation of previously acquired infection from this environment. In addition to that, it's the importance of understanding the social determinant of health in infection risk. And finally, drugs, which can play a double sword here. So although the chemotherapy is able to kill the tumor cells, at the same time, it also affects the immune cells and their ability to fight infections. So understanding the off-tumor on-target effects of these agents is very important. Also, their drug interactions with some of our antimicrobials help us understanding the risk overall. So with that lead us to how can we combat infections in this population? And this is what I call the Swiss cheese model. So starting with the vaccination, being our first line to prevent infections, and picking the perfect timing where the immune therapy or the chemotherapy may not interact with the efficacy of vaccine-induced immunity. Second is screening for infection, and this only happens when we have certain diagnostic tests that can detect certain pathogens. But because we can't screen for everything, we can't test for all, there is also role for antimicrobial prophylaxis here. And sometimes we need to use a hybrid approach of both in order to pick certain infections in high-risk population. And we need to stay also vigilant for any atypical form of presentations in these patients, as the chemotherapy and the immunomodulatory drugs may increase the risk for particular infections. So we always achieve these goals by working as a team with the heme-onc physicians, also optimizing our diagnostic tools in this population. So now let's look at the stratification of risk in these patients. So on this diagram, I'm showing the stratification based on the occurrence of the anticipated neutropenia, with the solid tumor patients being at the bottom of this because the chemotherapy they receive only induce a short or transient period of neutropenia less than 7 days, which make them less susceptible for opportunistic infections compared to the rest of the crowd here. And most of the infections they acquire are related to the local effects of the invading cancer to the surroundings, so related to disruption of anatomical barriers, obstructions, etc., or some side effects from the treatment they receive, for example, such as radiation. The second group in the middle, they are at risk for hypogammaglobulinemia that include patients with CLL, multiple myeloma, and that increases the risk for recurrent bacterial infection, recurrent viral infection with prolonged shedding. They are also at risk for intracellular pathogens because of their impaired cell-mediated immunity. They are less likely to suffer from invasive mold infections in general, but some members of this group may be at more risk related to some of the chemotherapy that they receive. The high-risk group here at the top, the main highlight for them are the acute myeloid leukemia and the MDS patients, where they suffer from prolonged neutropenia, which is the major risk factor for having invasive mold infection. In addition, they also suffer from cell-mediated immunity. And again, this does not meant to be a comprehensive list, but more of a rough stratifications and understanding that cancer patients are not the same in terms of infectious risk. Now let's look at some examples of infection that we commonly see in patients with solid tumors. Here I certified them by systems. And as I noted before, it's related to disruption of anatomical barriers. So we see a lot of infections related to obstruction, abscess formation, and also surgical site infection. And then I highlighted some agents that may predispose for opportunistic infections. For example, patients with glioblastoma, they are who are receiving temozolomide, they have impaired T cell immunity, which put them at risk for PGP, CMV, and others. If we go all the way to the bottom here, the therapy that they receive, we often see some side effects from the treatment. For example, radiation-induced pneumonitis, which can present as refractory pneumonias, where in fact it's totally non-infectious, enterocolitis, dermatitis. Also, some of the agents used can trigger some side effects that can masquerade as infections. For example, the MEK inhibitors and the BRAF inhibitors used in skin tumor can cause drug-induced fever. Okay, that leads us to the big question. How can we handle the evolving field of hemato-oncology and the ongoing expanding landscape of these agents that work at the molecular level? So a lot of these agents can increase the risk for acquiring new infections or reactivation of latent infections. And although they are really targeted towards a small molecule, they can sometimes have off-tumor on-target effects that can affect the immune response to certain infection and lead to some atypical presentation, which require us to actually fully understand the mechanism of action of these agents and how they can affect from collateral effects. So, and this slide is kind of busy, but it shows the complexity of these agents and their intricate mechanisms. For the purpose of this talk, I can go over all the agents, but I wanted to highlight two main agents here, which is rituximab, which is an anti-CD20, and BTK inhibitor with the first prototype, which is ibrutinib. These two agents, when the initial trials was conducted, there was no major concern for infections. However, the post-marketing study have shown that rituximab was associated with increased risk for PML. And for ibrutinib, there was more reports about increased invasive mold infection, and particularly aspergillosis in this population. So it's important to stay alert for these atypical findings. The other group of drugs that I would like to talk about is the immune checkpoint inhibitors, which have caused a revolution in modern oncology, now they are expanding to the hematology world as well. And by increasing the T cell activity against the tumor, we can also see some of these effects on the on the regular antigen and tissues, which can lead to a lot of inflammation as an adverse effect, and what we call as the immune-related adverse effects that can present as pneumonitis, hepatitis, colitis, encephalitis, and a lot of times we get consulted to rule out infections in these cases. The question comes, what are the type of infections these solid tumor patients who receive these agents are at risk for? So in one of the early studies that was done at Sloan Kettering, they looked at malignant melanoma patients who were receiving ipilimumab and nivolumab. And as we expect here that they are at risk of most of the infection they received, they had bacterial infections, and it's uncommonly to have fungal and viral infection. And if we take a close look at those who have this opportunistic infection, we'll find that these are the patients who actually developed the immune adverse events and received high-dose steroids. And those who were also refractory to the steroid and received infliximab were also at risk for this opportunistic infection. And the risk was also increased for those who were in combination therapy with ipilimumab and nivolumab. So in general, solid tumor patients who are receiving immune check inhibitor are not generally at risk for opportunistic infection. This agent does not inherently increase the risk for that. However, if these patients develop some of these adverse effects and require high-dose steroids, then we need to think about steroid-related opportunistic infections. And in order to protect them, it's recommended to give them pneumocystis prophylaxis if they're receiving high-dose steroid for a long time, more than 4 weeks. So I think all these examples show us the importance of the multidisciplinary approach to drug-related toxicity. And it's a lot of times we're multiple consultants and different types of teams working together to kind of solve the question: are we dealing with a drug side effect, or we are dealing with an infection, or we're dealing with a combination of both? And it's really helpful to have this open discussion with all members of the team in order to help our patients. Before I end this section of the talk, I would like to share with you some good resources to look for infectious complications of these agents. And one of the greatest efforts in the field was by the European group, the ECMID group, where they published multiple series of review articles going over all these agents. And that was not only limited to oncology, but rheumatology and others. That was published in 2018. The NCCN also have annual updates for these infectious risk. And every year, we as a group on the NCCN committee, we review the new agents and we create a growing table, as you can see here, of the infectious concerns, recommendations, and types of prophylaxis needed for these patients, if any. And the good news is this, is that all these information are free and available online, and you can access it at any time without even being a member. And most recently, the IDSA is working in a huge project looking into these infectious complications in a systematic manner with complete review of what's been published in the literature since the publication of the European guidelines in 2018. And there will be an online version of that that's interactive and web-based. So more to come in the coming years. Okay, now we'll switch gears and talk about how can we prevent infection in these patients. So antimicrobial prophylaxis is an cornerstone in prevention, but it's not for everyone. And not all the cancer patients need that. For example, solid tumor patients do not require any prophylaxis in general, except in certain circumstances. If we talk about antibiotics, this is usually reserved for patients with hematological malignancy, in particular patients with AML and MDS who have prolonged neutropenia. However, there have been changes in the field, and the benefit of that has been debatable, especially it has no impact on mortality, and it can lead to the growing problem of multi-drug resistance and its negative impact on microbiome. The other thing is the antiviral prophylaxis. So all cancer patients need to be screened for infection, for viral hepatitis, and those who are hepatitis B core antibody positive need to receive antiviral prophylaxis with tenofovir and entecavir, whatever is available in your place. For herpes, HSV, and VZV, patients with hematological malignancy and prolonged lymphopenia need to be on that. Also, some solid tumor patients who had prior HSV, they should also receive that type of prophylaxis. Also, if patients are on certain drugs, like ruxolitinib, for example, that increases risk for VZV, they need to be on prophylaxis. CMV prophylaxis is not universal, only reserved for allogeneic stem cell transplant. And last, antifungal. The risk for fungal infection is related to prolonged neutropenia for patients with AML and MDS, and these are the ones who usually require that. And then if there is increased risk for PGP in certain population, they should be on it. And there is a lot of details about that in the NCCN guidelines, so I will refer you all to read more about. Now, let's talk about management of neutropenic fever. So usually for these patients, we divide them into two main groups. Are we talking about a solid tumor patient or a hematological malignancy? So for the solid tumor patients, we consider them based on the mass score as a low-risk group. And if they are hemodynamically stable, and they tend to have a short period of neutropenia, less than 7 to 10 days. In this patient, they can be managed at the outpatient setting, no need for admission, and usually if the fever is related to the sudden drop in their counts, and they can respond well to oral antibiotics, which can be given, or sometimes observation. And if they are sicker, then they get admitted for antibiotics. The other group is the hematology patients. Patient because of their anticipated neutropenia, considered high risk, and they need to be admitted to the hospital for further management. So the first line of treatment for these for neutropenic fever at the inpatient setting is starting an anti-pseudomonal agents. And I included here the different types of antibiotics that target that. If they have no penicillin allergy, in our institution, cefepime is our first line. For those who have penicillin allergy, the alternative might be using these two agents, aztreonam and vancomycin, and the reason is you would like to also have gram-positive coverage with vancomycin, as aztreonam that has limited gram-positive coverage because these patients are at risk for streptococcal and MSSA infections. Vancomycin should not be given in all neutropenic patients. It should be limited to the list here. Patients who are hemodynamically unstable, those with pneumonia, or they have known MRSA infections, they have catheter exit site infections, or they have cellulitis. Okay, now I'll go over some common scenarios that we see. So you start your patient on anti-pseudomonal agents, but your patient continue to be febrile with negative culture. So what should we do? So it's important to know that 30 to 40% of the cases, this is what happens. We don't find a source, patient continue to be febrile. So that opened the question, what should we do next if they are not responding to antibiotics? So then antifungal. So we start thinking about whether this patient is at risk for fungal infection. So we need to investigate this further by doing some diagnostic, including CT chest and sinuses. And what agent to pick in this situation. So that depends on the clinical scenario and whether your patient was actually on antifungal previously or not. Okay, so you start your patients on antifungal, or and then after that the fever resolved, but your patients still neutropenic. You don't find a fungal source on them, and they are still on cefepime. So there are two schools of thoughts here about what to do with the antibiotic in this case. So either you continue the antibiotic until there is neutrophil recovery, and this is what the IDSA guidelines of the American have been doing since 2010, or the European approach of de-escalation and or stopping antibiotic if there is no source for infection is found in these patients. Okay. The other scenario that we also see is that the fever continues, but the patient looks great. So then comes the question, what should we do now? Are we missing something? Should we keep the antibiotic or should we escalate? You escalate, the patient continues to have a fever. So this has been a dilemma in the management of febrile neutropenia for a long time because of the lack of complete data for that. And what's important to know here that the recurrence of fever is really common in these patients. And as long as they are neutropenic, they have a fever, which led a lot of us in the field and to think about, is this fever actually infectious? And there are multiple terms for that, a fever of too many origins, or is it an inflammation of unknown origin? And there is a great article that goes through the historic view published in Annals of Medicine if you would like to see how the managements and thoughts have been in this field. Okay, now let's take a closer look at the European guidelines on managing these neutropenic patients. So we'll see if the patient is stable and afebrile, they actually recommend no change in the antibiotic, but even stopping antibiotics. For those who are stable but who are still febrile, they said no need to change antibiotics, and having continued fever despite being stable is not an indication for escalation of antibiotics. That was a big change in the mindset at that time. So there was some opposition when this was published in 2014, and there are multiple articles published actually arguing if that actually is ethical. And the authors of this guideline responded back by saying, no, it is ethical to stop antibiotic in this population, even though we didn't find a source. And their argument was that this approach of continuing antibiotic until count recovery was not based on solid science, but it was just based on years of experience and comfort and in the lack of data. And here I just copied what's actually written in the guideline as a justification for this type of recommendations. So this has been the case until in 2017, a group of Spanish clinicians published this trial. It's called the How Long study, where they compared outcomes between patients who had early discontinuation of antibiotics, which are the experimental group, to those who continued the regular approach. And as we discussed, 40% of these patients will have fever without a source. And they noticed also that fever would recur despite continuation of antibiotic in the control group, and stopping it early did not even cause worse outcomes. So based on this clinical trial, it actually confirmed that the fear of recurrent fever, infections, or mortality is not justified, and it's okay to stop antibiotics in those in hematologic malignancy patients, particular high-risk AML patients, if they are afebrile without an infectious source, and we shouldn't wait because sometimes for count recovery, because it may take weeks for them to recover their counts. So the NCCN have also changed their recommendation based on this trial, and they offer now different options for those who have resolution of their fever with low neutrophils. So they say either you can stop antibiotic, or you can switch to prophylaxis, or if you're still uncomfortable with all this, you can continue until count recovery. So now we are in 2024. What have been done to actually still answer this question of why these patients continue to have fevers? So there is the Australian group have looked into using the PET scan to look for some any occult infections and can help them actually de-escalate. And they found that this give them a lot of assurance, and they are utilizing that. Although this may not be applicable in a lot of places, we don't do that routinely in our institution. The other thing is the introduction of the plasma microbial cell-free DNA next generation technology, which can detect a library of pathogens, bacteria, viral, and fungi. Also, this is not available in all places, and it can detect pathogens that are not clinically significant. So more to come in the field as we learn more about these patients. So what we do in our institution here, so we take the individualized approach. So for those who don't have a source for their infection and they continue to be febrile, we usually require an infectious disease consult on them. For those who we have not identified a source of infection, but their fever went away, we encourage de-escalation to prophylaxis. And then we usually treat for the duration of infection without continuation until counts recovery. With this change in our management approach, we noted a decrease in our anti-pseudomonal utilization since we adopted this new guidance. Okay. The other question is we've been using cefepime and piperacillin and tazobactam as a first line for decades now. The question comes, are these first line agents still functional against the growing multi-drug resistance? So we participated in this cross-sectional study. We provided isolates, and in this along of the cancer centers in the US. And as you can see here, that cefepime remains active against 93% of pseudomonal isolates and 85% of the Enterobacterialis. And we can see here in fluoroquinolone that the susceptibility is decreasing. It's quite bad here, and which is a reflection for our years of prophylaxis. So this shows us the collateral effect of utilization of antibiotics. So this study can confirm that our current guidelines of continuing anti-pseudomonas agents still applicable with cefepime or piperacillin tazobactam as a first line. The other thing that we need to think about when managing these patients is the non-infectious causes of fever, which is actually common in these patients. And this could be related to drugs that they are receiving, whether it's antibiotic, non-antibiotics like antiepileptics, or even some of the chemotherapy they receive, considering some syndromes that are common, like in AML patients, we see a lot of sweet syndrome that can present with this erythematous, purplish nodules, and cause very high fever in certain situations. I also listed here some of the lung complications that we see in these patients, like pulmonary hemorrhage, and that can cause also high fever. So when we evaluate this patient, we need to have this bird's view of the big picture and realizing that there are multiple factors that contribute to fever other than infection. Okay. So the other thing I would like to talk about is who at risk for fungal infection. So if we remember our stratification here, solid tumor patients are at minimal risk for invasive mold infections. And the group that we worry about the most for that are the leukemia patients, in particular the AML patients, the ALL patients, and those who underwent stem cell transplant and have GVHD and receive high-dose steroids. So the risk factors for fungal infection are complicated, and understanding the comorbidities for that is crucial because patients who are diabetic, who are uncontrolled, are at a have augmented risk for fungal infections. So fungal infections tend to be very difficult to diagnose in patients with hematological malignancy. For example, if you have a patient with lung nodule, it's hard for you to get a sputum sample, it's hard to grow the fungus. And if you want to get a biopsy, it's always limited by having thrombocytopenia. Because of that, we all follow this European guidance of classification of fungal infections that rely on different criteria from the host. Is this the right host to have the fungal infection? Do they have the clinical findings? Do they have any microbiological evidence? And because of the difficulty in that, there's a lot of fungal diagnostic that have been introduced to the market to assist with that. Some of it, like the galactomannan, that can help. The 1,3-beta-D-glucan. We've been using it in the past until most recently when the guidelines changed and said we should not be using it for invasive fungal infection, but just for PGP. So usually when we look at how can we combat the risk of fungal infection in these patients, again, first line would be prophylaxis if able. If the drug is available, if it's covered by insurance, if it does not confer any drug interaction with their chemotherapy. But if we can't use an agent, then we will go through the preemptive diagnostic approach where we check certain fungal diagnostics. But that also add a level of logistic and cost if the test is not available in certain settings. And sometimes we use a combination of both, or we wait or monitor the patients closely for any early signs of infection. And there is also some issues with using this fungal diagnostic while we are monitoring infection in these patients, and we need to be aware with the limitation of this testing and the lack of high sensitivity and specificity. And also being on antifungal prophylaxis can reduce the risk, can impact the result of these tests. So when we manage patients with fungal infections, first line is using antifungal that have the susceptibility for that. Usually we don't ask for susceptibility unless there is a concern for resistance, so it's assumed. And then the other important thing is surgical debridement, and this an important element if we are dealing with infections like mucormycosis, where getting rid of the infection is very important. There are a lot of other agents that are still under clinical trial. And usually we treat for a long time, several weeks, until there is a resolution, for example, for fungal pneumonia, and repeat another CT chest. And if the patient is still at risk for recurrent infections by not recovering their counts, we tend to place them on prophylaxis until they recover their cells. So with that, I'd like to end and highlight certain points of this talk, that cancer patients are at risk for both community-acquired and hospital-acquired infection, in addition to opportunistic infections, which lead us to complete understanding of the impact of their cancer and the effect of their chemotherapeutic agents in order to reach the proper diagnosis. And then doing a good history taking and physical exam in order to find subtle signs of infection. And because of the growing field of these chemotherapeutics and immunomodulatory agents, it's important to stay alert for this atypical pattern and how these agents impact the immune system. And with that, I'll stop here and happy to take questions.
Great. Thank you so much, Dr. Zainab. And again, everyone, feel free to submit your questions into the Q&A box. Again, this is neutropenic fever in cancer patients, so it's a little bit targeted focus, and it was a request made by you all. So Zainab, there are some questions within the Q&A. I don't know if you could see them. I could repeat the question, and then you can respond.
Yeah, I can see them.
Perfect.
Because it's the same. So the first question is about, is the management of neutropenia because of other conditions the same? In Northwest Ethiopia, we have visceral leishmaniasis, patients who have severe neutropenia. So that's a good question. So when we are talking about a disease that causes neutropenia, and you have an intact other immune functional cells, so that's different from someone who is an AML with completely dysfunctional cells and other cell lines. But I think usually the rule we use is it depends on the duration, right? So if your patient is neutropenic and coming with a fever, you should do the first lines of therapies, right? Providing them with an gram-negative coverage. So if that answers you the question. And then the second question was the role of G-CSF and the neutropenic fever. A good question. So this, so it's not a must that you need to give it, but sometimes it helps by inducing recovery of counts earlier. And we see this practice a lot by the hematologists in certain types of malignancies, because patients respond to chemotherapy differently. So if there is an anticipated recovery and it doesn't happen, so yes, it can help reducing the time of neutropenic fever by giving them GCSF. Any role for procalcitonin to stop? Okay, good question. So the procalcitonin, because it's an inflammatory, it can be elevated in this patient regardless of infection. And there have been studies that looked into that, and it have been controversial. So technically, I don't use it in hematological malignancy because it can be elevated because of the tumor burden itself and the inflammation. But maybe in certain solid tumor patient, we can find some role for it. Okay. Let's see here.
While we're waiting for more questions, Dr. Hiwat, our co-moderator, please.
Thank you, Dr. Zainab, for your excellent presentation. So maybe to add some points on the visceral leishmaniasis question.
Yes.
Most of our patients with visceral leishmaniasis, one of their main manifestations is fever, as a pentadosis, concomitant hepatosplenomegaly, commonly splenomegaly is commonly found. Pancytopenia is also one of the manifestations, but most of the patients will present with anemia, but they can also present with neutropenia and thrombocytopenia, hypogamma globulinemia, and the patients can also have this prolonged fever is one of their manifestations. So it won't be as similar as other malignancy patients. Visceral leishmaniasis is also an infectious disease. So since fever is one of its manifestations, we don't have to maybe treat things. We have to screen them for secondary bacterial infections before treating them for like other neutropenic patients with broad spectrum antibiotics. Even though they are at risk, this high-grade fever can be the manifestation for the underlying disease, which is visceral leishmaniasis, and which will be improved by treating the underlying disease. Most of the patients will improve within 2 weeks. Will have improvement of their fever within 2 weeks. So it may not be translated like the same as neutropenic patients due to malignancies, meaning in acute leukemia patients.
I agree with you because it's two different hosts. Yep. Thank you for your expertise in the topic. There is a question here about how to differentiate cancer fever versus infection fever in neutropenic fever. So there was this old test called the naproxen test. It was published in the 1990s. Sometimes we use it in solid tumors, and I think an important way to identify that is by doing a thorough infectious workup. And if all the results are negative, then that increases the probability that we are dealing with a cancer fever rather than an infection fever. And sometimes we often give them either non-steroidal anti-inflammatory or sometimes steroids, and this is what we see with lymphoma patients or those with solid tumor and hepatic metastasis. And someone is raising their hand.
I think Dr. Shu-Hua, is that still an old hand or is that a new comment? And I also want to remind all the attendees, there is an evaluation survey for Dr. Zainab. If you could please fill that out, that would be wonderful. And once you complete the entire workshop today, you will also be receiving a certificate of attendance. So thank you again. I don't think there are any other questions in the Q&A.
All right. Well, thank you, everyone, and happy to receive any questions by email if needed. Thank you so much.
Thank you again, Dr. Zainab, for the wonderful lecture. She is truly our hematology oncologist, infectious disease specialist here, and you can clearly tell by her passion in the subject as well as her expertise serving on many committees. If you could unshare your screen, Dr. Zainab.
Yeah.
Perfect. Now, Dr. Natalie, perfect. Thank you. It's in the oh, perfect, wonderful. Whenever you're ready. Dr. Natalie, we're not able to hear you.
Hi, can you hear me okay now?
Yes, thank you.
Okay, sorry about that. Hi, so I'm Natalie. Today I will be presenting on different antiretroviral therapy topics. So with this being such a large topic, we kind of narrowed it down to a few select points to discuss today. So first, I will review our newest agents for treatment and prevention of HIV and the long-acting antiretrovirals. We'll also then discuss treatment in the setting of virologic failure to first-line therapies, and then finally review some of the options available in HIV prevention. So again, beginning with long-acting injectable medications. first discussing the combination cabotegravir and rilpivirine, available as brand name Cabenuva. So this medication is our first and only fully injectable complete HIV treatment regimen. This medication is unique in so many ways, but there's a lot of points that you have to consider as you think about starting this particular medication in one of your patients. So this medication is approved to be started only in patients who are virally suppressed on a stable antiretroviral regimen before that switch is made. We'll talk a little bit more later about some scenarios and emerging evidence that we may be able to use this medication in patients who are not virally suppressed as well. But that is the indication, at least for right now. Each time a patient receives a dose of this medication, it is 2 separate shots and it is given into the gluteal muscle. So it's important to make sure that your patient is fully aware of, the administration details so that they can, be mentally prepped for that first injection. Unfortunately, this medication can only be administered by a healthcare professional currently. I'm not aware of any potential changes in the near future that might be able to be self-administered at home. So you do have to make sure that you have the resources and the personnel available for this medication to be administered. Prior to the start of injectable rilpivirine, there is the option to do a oral lead-in of the medication. When first approved, the oral lead-in was mandatory for this, but after more evidence was collected, it was found that this could be safely started as a direct to inject treatment. So in our practice here, most of our patients are now opting to receive direct to inject, so they are skipping over that oral lead-in. However, if I have patients who, historically have just not tolerated medications well in general, or who I feel are at greater risk of side effects, we are more likely to opt for that oral lead-in, keeping in mind that you do have to meet all of the administration requirements of the rilpivirine. So avoiding like proton pump inhibitors and other medications that may reduce stomach acidity, as well as the food requirement of 400 calories with each dose. So there are 2 different dosing options for rilpivirine. It was originally approved as a monthly injection. So after completing potentially that 28-day oral lead-in, then the patient would receive a loading dose of 600 milligrams of cab and 900 milligrams of rilpivirine. And then subsequent to that, every month or every 4 weeks, the patient would receive an ongoing dose of 400 milligrams of cab, 600 milligrams of rilpivirine. Definitely the more common dosing strategy now is the every 2-month injection. The picture there is from the drug manufacturer's website, kind of outlining what that looks like. So optional oral lead-in to begin with. And then after that, the patient receives the 600 and 900 milligram doses. That dose is repeated 1 month later. And then after that, the patient can receive every other month dosing. Side effects with this, particularly injection site reactions, are extremely common. So patients will almost always experience pain, not only with the injection, but more so after the injection. So most of our patients are beginning to feel sore about 24 hours after that shot, and then that soreness tends to last for 3 to 5 days. The first injection is typically the most painful injection, and then the next 2 to 3 injections get progressively more mild, and then after that, the patient will kind of stay at a consistent pain level thereafter. Out of all the patients that we've started here at our practice, I've only had one who has said that injection was just too painful and that they did not wish to continue with the injections. So most people feel like that is a tolerable side effect overall. And then we recommend like anti-inflammatory medications as needed to treat that pain. Nodules are also not uncommon. Patients tend to experience those for a few weeks and sometimes for a few months before those nodules resolve. And then, of course, induration is also a possibility. Other side effects that are potentials with this include weight gain, since we are using an integrase inhibitor-based therapy, and kind of that class effect that we see of potential for weight gain, potential headaches and mood changes with the rilpivirine portion. And then I think it's important to call out that post-injection reaction. We have had a couple patients here at our practice site who have experienced a post-injection reaction. I warn our patients here that a post-injection reaction feels a lot like an allergic reaction. So with shortness of breath, it can cause chest pain, anxiety, sweating. The reaction does begin almost immediately after the injection of the rilpivirine. So it's only associated with the rilpivirine. And then the reaction does self-resolve after 10 to 15 minutes. The thought here is that the post-injection reaction is a product of the rilpivirine being accidentally administered intravenously. And so there's a rush of rilpivirine into the bloodstream and causes that reaction within the body. So because of that mechanism of action, if a patient were to experience a post-injection reaction, it's not a contraindication to continuing the medication. They're no more likely to have that reaction at future injections than anyone else in the population. Dosing for this medication is really key. So each injection has a window of safety. So it can be administered up to 7 days before or 7 days after the scheduled dose is due. Now in practice here, sometimes we're a little more conservative on that window. And I have seen other institutions that are also limiting that window a little bit more just because of issues that have been seen with breakthrough viremia a little bit sooner than that end of that 7-day window. If an injection is not given in the window, it's important to bridge the medication. Bridge should be started at the date of the missed injection and can be given either with oral cabotegravir rilpivirine or whatever their prior effective ART regimen was. At our practice, we're usually going back to their prior effective antiretroviral therapy only because of accessibility issues with cab and rilpivirine, because here it has to come from 2 separate pharmacies, and so there's a lot of coordination involved. And again, those issues with rilpivirine administration that has to be taken into consideration for the patient. Once a bridge has begun, it is continued until the injection is given. If the patient is more than 1 month late for the next injection, they do need to repeat that loading dose. So either the higher 600, 900 milligram dose if they're on monthly injections, or the more frequent 4-week dosing if the patient is on the 8-week injection or 2-month injection schedule. Again, some institutions are a little more conservative than the 1 month. I've seen some places that are recommending a repeat loading dose of as soon as 15 days after the missed dose. So that is, somewhat at the discretion of the provider. There is a very real risk of resistance developing if these medications are stopped without also starting oral therapy. So I think it's important to call out here the half-lives of these medications. So cabotegravir half-life is 5.6 to 11.5 weeks, whereas the rilpivirine half-life is essentially double that. So if patients were to discontinue injections without also starting an oral therapy, that is a very long time to be on rilpivirine monotherapy. And monotherapy, particularly in a medication that has a fairly low barrier of resistance. Eligibility for this medication is a little bit unique. Patients here, again, should be virally suppressed prior to switching. That's the way the medication has been studied. But I think this really will change as more data emerges. There has been a few studies that I've seen that have looked at patients who are not able to reach an undetectable viral load and are, started on rilpivirine while they still have a significant viral load, and they've generally done very well. And so I think, again, as more data evolves, that this is going to change. Ideal candidates for this medication should have no resistance to either component. We screen very carefully, especially in patients who have a history of non-nucleoside exposure with, for example, an efavirenz-based regimen, to ensure that we are eliminating, if at all possible, patients who may have an underlying non-nuc mutation that may make that rilpivirine less effective. Because neither of the agents here are active against hepatitis B, ideal candidates should not have a hepatitis B co-infection. Also important to screen for hepatitis B immunity and to vaccinate if indicated, to reduce that risk that a patient may experience an acute hepatitis infection. They also need to be able to maintain adherence to their injection schedule because of that risk of developing resistance if injection dates are missed. There are risk factors for treatment failure, including but not limited to, again, pre-existing INSTI or non-nuc resistance, a BMI greater than 30, and an HIV subtype A1. The BMI and HIV subtype, when present as a single risk factor, don't increase the risk of treatment failure, but when combined with other risk factors, do have this cumulative increase in risk of failing the medication. So there are extensive studies that have been done looking at this medication combination. I'm going to review just a few of the highlights, beginning with the ATLAS trial. So the ATLAS trial compared monthly rilpivirine injections to continuing standard oral therapy. They found that this was non-inferior. The study enrolled 616 patients and found that patients who were placed on the long-acting rilpivirine had a failure rate, so an HIV viral load greater than 50 at week 48 of 1.6 compared to 1.0 for patients who were continued on current oral therapy. It is, I think, important to note that virologic failure occurred in 3 of the 308 RPV patients, and we'll discuss that in a little more detail in future slides. So after the success of the ATLAS trial, the ATLAS 2M trial was completed. So this trial enrolled both participants of the ATLAS trial in both the active and the standard oral therapy groups, in addition to additional participants to reach their N of 654. Patients here were randomized 1-to-1 to receive either RPV 600, 900 milligrams every 8 weeks or RPV 400, 600 milligrams every 4 weeks. They found that the 8-week dosing was non-inferior. So at week 96, which was their extension of the trial, they found that 91% of patients in the 8-week group versus 90.2% of patients in the 4-week group had maintained an HIV viral load of less than 50. They did, again, experience some viral failures within this group. So in the Q8-week group, they saw 9 confirmed virologic failures, with 7 of those 9 showing new RAMs, new resistance mutations to rilpivirine, and 5 of 9 having INSTI mutations that had developed. The Q4-week group also had viral failure, but not at nearly the rates as the 8-week group. So 2 of those patients, again, with 1 developing RPV RAMs and both developing INSTI RAMs. And then finally, the Latitude trial is a recent publication. It enrolled patients who had a history of difficulty maintaining adherence, and that was defined as either a viral load greater than 200 copies per milliliter or a loss to follow-up. 434 patients were enrolled. There were multiple steps to this study. So step 1 consisted of 24 weeks of a standard oral treatment with monitoring symptoms for those patients if they were able to reach viral suppression. Step 2 included patients who were able to reach a viral load of less than 200 copies per ml in step 1, and then they were randomized to either monthly CAB-RPV or continued standard oral therapy. I think it's interesting to note that they did not do 8-week dosing in this trial, but instead used that 4-week dosing strategy. Primary endpoint here was virologic failure plus discontinuations, so treatment failures. It was superior. So CAB-RPV patients had a 24.1% failure rate versus a 38.5% failure rate in standard oral care. And then it was superior in those secondary endpoints. So virologic failure and then treatment failure were both significantly better in the CAB-RPV groups as opposed to the oral therapy. 2 patients in each arm developed new resistance mutations. Both of the CAB-RPV patients who developed new mutations did have INSTI mutations noted. Because of the ability to establish superior efficacy with those secondary endpoints, this study was ended early, and all patients were offered CAB-RPV at the end of the study. And then moving on to lenacapavir. So this medication is a part of a novel class of antiretroviral therapies called capsid inhibitors. They impact several steps of the HIV life cycle as part of their mechanism of action. This medication was approved for treatment of heavily treatment-experienced patients. It is not a standalone therapy, so it needs to be paired with what's called an optimized background regimen. So finding the most effective medications that are still available for that patient, and then making sure that patients are on 2, preferably 3 fully active medications, including the lenacapavir. This medication is an abdominal subcutaneous injection, which is administered by a healthcare professional. Adverse reactions are relatively mild, so injection site reactions as expected. I think an important call out here is the nodules that can be seen with this injection tend to persist for a very long time. So at the close of the Capella study, there were several patients who had persistent nodules throughout the duration of that treatment. And then it can also lead to an increased serum creatinine. This medication does require an oral loading dose in conjunction with the first injection, and there are 2 different ways to complete that oral loading dose. The 2-day initiation, I think, is by far the most common one, but the 15-day initiation is also an approved way to initiate the medication. The 15-day initiation is what was used as part of the Capella study, and I'll kind of go through why they dosed it that way. But the 2-day initiation was approved as based on the results of pharmacokinetic studies. And so with that 2-day load, the patients are given 600 milligrams, so 2 tablets of oral lenacapavir the day of their first injection, and then an additional 600 milligrams the following day. And then after that, maintenance dosing here is 927 milligrams, so 2 injections every 6 months. With the longer dosing interval also becomes a bigger injection window, so this can be safely injected plus or minus 2 weeks from the predicted date of the next injection without needing to be reloaded. So the Capella trial is the trial that brought this medication to market. This trial enrolled patients who were failing treatment with their current antiretroviral therapy as defined by a viral load of greater than 400 and had documented resistance to at least 3 of the 4 major drug classes. So INSTIs, protease inhibitors, nucleoside and non-nucleoside reverse transcriptase inhibitors. Patients were then assigned in a 2-to-1 ratio to either add lenacapavir, which was cohort 1, or placebo, which is cohort 2, to their failing regimen for 14 days. So this was an effective monotherapy portion. The endpoint here was a 0.5 log reduction in viral load. They saw that in 88% of patients on lenacapavir versus 17% of patients on placebo. So this need to see if, as effective monotherapy, the lenacapavir did have a significant reduction in viral load is the reason that that 15-day loading dose is what was studied in the trial. At the end of that 15-day loading dose, all patients either received their sub-Q dose of lenacapavir or they started the oral load. So patients who had been in that placebo group then started oral loading dose on day 15. At week 26, 81% of patients in cohort 1 and 83% of patients in cohort 2 had experienced a viral load of less than 50. CD4 counts were pretty impressively increased as well. So just a great additional option for our patients who have developed resistance to so many of those drug classes. 8 of the 72 patients did develop lenacapavir resistance, and that does develop fairly quickly in some cases. Most of those patients were noted to have that M66I substitution, and some of those patients were on essentially monotherapy of lenacapavir because they had 0 fully effective medications available to them. Lenacapavir has a lot of exciting things on the horizon for it. So if you've seen the PURPOSE trials that are currently going on, PURPOSE 1 just announced their results. This was a trial for HIV prevention in adolescent girls and young women. They found that lenacapavir was 100% effective in preventing HIV transmission. PURPOSE 2, 3, and 4 are all ongoing with different treatment populations. And so it will be exciting over the next year to see where those trials end up and when we're able to bring this every 6-month injection for HIV prevention to market. Also on the horizon for lenacapavir includes treatment-naive patient options as part of an oral therapy. So looking at oral bictegravir plus lenacapavir, and then also in combination with other injectable antiretrovirals as part of a longer dosing interval. So, potentially with broadly neutralizing antibodies for hopefully a 6-month dosing interval. We're also seeing it being used in combination with the currently available injectable cabotegravir plus or minus rilpivirine for patients who may have underlying resistance mutations that may make them unable to receive cabrilpivirine alone, but who also may not be able to adhere to an oral dosing schedule. So moving on to from there, we'll talk about resistance to first-line agents and strategies for that treatment. So resistance can be either transmitted, so those mutations come from the patient who is giving that infection where that virus came from, or it can be acquired. Acquired resistance is more common and can be due to a variety of factors. So adherence difficulty is by far the most common reason that we're seeing for acquired resistance developing, and that can be due to so many different issues, whether that's comorbidities like mental health issues or drug use, issues with accessing the medication due to cost or availability, the stigma of HIV infections and patients who may hide their medications or not be willing to have the medications in the house, and then lack of basic resources like food or housing that may make medication adherence impossible due to storage or the need to take medication with food. Low drug levels can also be a factor here, whether that's due to poor absorption, maybe due to chelation if taken in combination with products containing divalent cations like calcium, magnesium, zinc, or food requirements such as the rilpivirine that we mentioned earlier. As well as metabolism issues, so drug-drug interactions if the medications are taken in combination with CYP3A4 inducers, so like our integrase inhibitors are subject to that kind of a drug interaction. Patients who are on antiretroviral monotherapy, whether that's due to incomplete regimen, due to prescribing issues or access issues, or if they are resistant to the other components of the regimen that they're being prescribed. And then also high pre-treatment viral load does increase the risk of developing resistance with certain dosing combinations. So resistance testing is important in determining the next steps for treatment for patients who are noted to be failing their regimen. As long as resistance testing is available and timely, the recommendation is to leave patients on their failing regimen until you can determine the mutations. And that's to keep the viral load as low as possible, so that way when that switch is made, the new agents don't have to drive the viral load down as far to reach that undetectable state. There are multiple kinds of resistance testing available. So a genotype is available in two different ways. The conventional or Sanger sequencing is what we're using most commonly. So that is looking directly at that viral RNA. Because of that, patients do need to have a detectable viral load. It can be consistently run if viral load is greater than 1,000 copies per ml, but it's worth a shot if patients have a viral load of at least 500. You may have some success in getting results even in those patients who are a little bit lower. This is also most useful when the virus is under pressure to express those mutations. So the virus will tend to revert back to a wild type virus and not express those mutations if they're not under the pressure of that medication to express those mutations. So if a patient is returning to care after several years out of treatment, they may not show you all of the mutations that they had accumulated in the past. Because of that, it's important to make sure that you gather all historical genotypes that have been completed for your patient and to take into account all of the mutations that have ever been noted as you're making those treatment decisions. It's also possible to complete a proviral HIV DNA genotype looking for archived mutations. So instead of looking at the HIV RNA here, this is looking at archived bits of HIV DNA in the host cells. Because of that, it can be completed in patients who have an undetectable viral load. This test is accurate. If it finds a mutation, you can trust that that is a true mutation and take that into consideration in your treatment decisions, but it may not always pick up all of the mutations are there. So just because you don't see a mutation on your archived genotype doesn't necessarily mean that you may not see it expressed in the future if it is hidden away somewhere. And then finally, HIV phenotyping is not something that we're commonly using here, but it does have some utility when you're looking at the extent of residual activity that a virus might have to certain drug classes. So in patients who have extensive mutations and you're trying to decide what still has partial activity for them, there may be some utility of this particular phenotyping to be completed. And then I also want to just go over some definitions before we get into the management of treatment failure. So virologic suppression is defined as an HIV RNA that is less than the lower limit of detection for your lab. So here at our institution, it is less than 40, but that does vary from one lab to another. A blip is something that happens after virologic suppression. Patients have an isolated detectable viral load, and then they quickly return back to suppressed viral loads. This can happen if a patient has experienced a reservoir that has burst or lysed and then released maybe non-replicating virus into the bloodstream. So there's not really anything that needs to be done if you have a patient who experienced a blip. Low-level viremia is defined as a persistent viral load of less than 200 copies per milliliter. Again, this can be due to fragments of non-replicating virus that is, in the bloodstream. It may also be due to patients who are maybe intermittently non-adherent or have other issues that may result in these low-level viremias. A virologic rebound is a patient who is able to suppress, but then has a viral load greater than 200. Incomplete virologic response is a patient who is on therapy for at least 24 weeks and is never able to suppress the virus. And then a failure is an inability to achieve or maintain a viral load of less than 200 copies per ml. So the top three there are all things that we don't need to make any changes. We don't need to address those. So low-level viremia, although you may see that virus there, our data shows us that those patients are not likely to fail their therapy and they don't need to have medication switches. Patients who experience one of those bottom three scenarios would need to be considered to have medication changes to put them on a effective antiretroviral regimen. So this kind of just reiterates that. So patients who have a viral load of less than 200 don't need to have anything done with them beyond continuing to monitor their viral load a little more frequently with 3-month monitoring recommended. If your patient has a viral load between 200 and 1,000, it's best to try and do genotypic testing, although as mentioned before, may not be able to find results because of that low viral load. If you cannot perform a viral load, you can try the proviral DNA testing versus just empirically switching the regimen. Patients who have a viral load of greater than 1,000 and whose genotype is without drug resistance mutations noted, those patients are most often just poorly adherent to their regimens. So in that scenario, it's important to assess and address those issues. So talk to your patient and find out what is going on that is making it difficult for them to take their medication, and then address based on those factors. If the regimen is well tolerated and you can address the adherence issues, that's best, and just leave them on their current regimen. If the regimen though is being poorly tolerated, if the patient is experiencing like nausea or vomiting, diarrhea, and that is leading to poor adherence, considering a regimen change in that scenario can be helpful for the patient versus treating those symptoms. If you do make those changes, the viral load should be repeated in 4 to 8 weeks, and then repeat the genotype if that elevation persists despite adherence changes. And then finally, if the patient has a viral load greater than 1,000 and there are new drug resistance mutations, the regimen should be changed as soon as possible. We know that this will reduce the likelihood of picking up additional mutations and also that virologic response rates are better with a sooner switch. So based on the regimen that they're failing, there are many things that you can take into account as you consider what the next regimen should be. So if you have a patient who is on a non-nucleoside plus a nucleoside reverse transcriptase regimen, that treatment failure is most likely due to failure and resistance to the non-nucleoside component. Those patients may or may not have resistance to NRTIs as well, with the most common being XTC. So 3TC or FTC, lamivudine or emtricitabine resistance, like the M184V mutation. In this scenario, based on what your resistance mutations show you, switch options include moving to a not non-nucleoside based regimen. So switching to an integrase inhibitor such as dolutegravir or bictegravir, plus 2 NRTIs, at least one of which should be fully active. So for example, if your patient did have the M184V mutation, if you're switching to an RTI backbone that contained tenofovir, alafenamide, plus emtricitabine, you would have the fully active tenofovir product and can move forward with that regimen. You can also use a protease inhibitor plus that NRTI backbone, or a protease inhibitor plus INSTI combination. If your patient is on a protease inhibitor plus NRTI backbone and failing that regimen, that resistance is most likely due to poor adherence. And that is because the protease inhibitors have such a high barrier to resistance that it is very difficult to truly fail a protease inhibitor-based regimen. Not impossible, but less likely. Those patients also may have picked up XTC resistance. Switch options in this scenario include switching to an integrase inhibitor, whether dolutegravir or bictegravir, plus NRTI backbone. If both of your NRTIs are partially active, so there's not a fully active NRTI available, it is acceptable to put the patient on dolutegravir plus 2 partially active NRTIs, knowing that the NRTI class tends to maintain some residual activity fairly well. You can also consider switching the patient to an alternate protease inhibitor plus NRTI backbone based on results of your genotypic testing. There's also evidence to support continuing the regimen as is with adherence changes, again, due to that likelihood of the protease inhibitor maintaining its efficacy due to high barrier to resistance. For the integrase inhibitors, you have to further break down whether you're failing a first generation or second generation integrase inhibitor. So for first generation elvitegravir or raltegravir failure, that's most likely due to INSTI resistance developing. In this scenario, the patient may retain susceptibility to dolutegravir. So again, results of that genotype is crucial. And then patients may or may not have developed NRTI resistance. So switch options here include a protease inhibitor plus an NRTI backbone. If you have partial activity of your dolutegravir still or full activity of the bictegravir, you can dose the dolutegravir twice daily and then add on an NRTI background, or consider twice daily dolutegravir dosing plus a protease inhibitor. If failure is with your second generation integrase inhibitor, so dolutegravir or bictegravir, again, due to the high barrier to resistance of these agents, resistance to the integrase inhibitors is unlikely. So here, resistance is most likely due to NRTI failure with potential for INSTI resistance. So again, based on the results of those genotypes, you could switch them to a protease inhibitor with an NRTI backbone. You could also potentially switch them to a single tablet regimen. So for example, if your patient is taking dolutegravir plus 2 NRTIs here in the United States, that's not available as a single tablet regimen. So we may switch them to a bictegravir-based regimen so that they can have 1 pill once a day and hopefully improve that adherence. And then finally, again, protease inhibitor plus dolutegravir is a possibility. And then CAB-RPV kind of brings its own nuances. So as we outlined previously in the Atlas 2M trial, specifically 5 of 8 patients who failed that treatment were later found to have archived non-nucleoside resistance. And so they were, much more likely to have failed that therapy. All of those patients retained phenotypic susceptibility to dolutegravir. Real world data that is emerging may be different to that. In our practice here, we've had 3 patients who have failed CAB-RPV, and of those, 2 of them need to be switched to a protease inhibitor-based regimen because they had developed some pretty significant INSTI mutations. So again, based on results of genotype, you can switch to an oral INSTI with dolutegravir or bictegravir plus NRTI backbone or protease inhibitors based regimen. If you don't have genotypic testing available, I would empirically switch to a protease inhibitor just based on the experience that we've had here thus far. And then finally, second line failure and beyond should really be managed by someone with extensive knowledge of interpreting HIV genotypes and HIV resistance management. In general, though, if you have a fully active either INSTI or PI, you can either pair one of those up with an NRTI backbone or combine them together for a PI plus INSTI regimen. If neither of those are fully active, general guidelines include use of 2 or preferably 3 fully active agents. If there are less than 3 fully active agents available, include partially active agents, so potentially NRTI medications that may have partial activity remaining. And then, of course, considering alternate classes of antiretroviral. So the post-attachment inhibitor ibolizumab, the GP120 attachment inhibitor fostemsavir, or the capsid inhibitor that we discussed earlier, lenacapavir. And then finally, we will outline treatment options for PrEP. So as part of talking about PrEP, I think it's first important to mention U equals U, or undetectable equals untransmittable. We have multiple trials that have shown that this science is there and that patients who maintain an undetectable viral load cannot transmit the virus. That being said, PrEP, or pre-exposure prophylaxis, is one of the most effective things that we have to prevent HIV infections. Daily PrEP reduces the risk of HIV acquired through sex by greater than 90% and greater than 70% for patients who are at risk due to injection drugs. For patients who are starting PrEP, the protocols that we follow are pretty specific to ensure that the patient who is being treated is not infected with HIV and being given a partial regimen that may drive resistance before discovery of the infection. So for patients who are prescribed oral PrEP, we're testing for HIV infections every 3 months. And if they are using injectable PrEP, we're testing every 2 months. Oral options here include emtricitabine and TDF, as brand name Truvada. This was the first PrEP medication that was approved, includes oral daily dosing. There is an option for on-demand dosing, but we're not going to review that today. This resulted in good levels at all potential sites of infection with relatively low toxicity and good tolerability. Also knowing that TDF has that high genetic barrier to resistance, so we're not driving NRTI resistance if someone were to become infected while they're taking PrEP. And then here in the US, having that medication as available as generic is a big access driver. Emtricitabine and TAF was approved later in 2019. Testing showed that it was non-inferior to the TDF-based regimen. Again, once daily dosing. This medication was not approved for people who are at risk of HIV infection through vaginal sex. However, the Purpose 1 trial that was recently studied did include a TAF-based regimen in their protocol and compared it to TDF with good results. So I think that will be changing more in the future. And then cabotegravir is available by itself under brand name Apretude as a preventative medication. Dosing here is essentially the same as the every other month, every 8-week CAB RPV. So loading doses at month 1 and month 2, and then ongoing doses every other month. Same option for oral lead-in is available with CAB by itself. This medication did demonstrate superior efficacy to oral TDF-FTC in the HPTN 083 and 084 trials. It is very expensive though, and so that is something that we do have to continue to take into consideration. It's also important to note that this has a very long pharmacokinetic tail. So it takes the body a long time, up to 12 months, to fully eliminate the cabotegravir in the body. Because of that, quarterly HIV testing is recommended for 12 months after the last dose is administered. And part of the reason for that is the Levi syndrome. Levi is the long-acting early viral inhibition syndrome. This has been noted in patients who are receiving cabotegravir for PrEP, and it can cause delays in HIV diagnosis. And so for patients who are experiencing this Levi syndrome, they can have antibody testing that doesn't come up positive right away. It can also revert back to negative after a positive test. The viral load may remain below the level of quantification for an extended period of time. So in the experimental testing that was done, they found that patients often had single-digit viral loads at the time of diagnosis. in the US. Because of that, we are completing both an antibody and an HIV viral load at each injection. In those rare instances where infection happens during administration of cabotegravir, they found that 10 of 18 patients did develop INSTI resistance if they had received a cabotegravir dose within 6 months of that HIV acquisition. So because of that, if HIV infection is at all suspected, patients should be initiated with an empiric treatment of a protease inhibitor-based regimen plus a 2-NRTI backbone. And that should be continued until if at any point the patient is able to obtain genotypic testing, although probably unlikely given the ability for that protease inhibitor-based regimen to quickly suppress the viral load. And then this just outlines what that testing might look like in a patient. So this is testing completed for a patient who was confirmed to have an HIV infection while receiving cabotegravir. And so you can see, you know, the rapid test and the antibody test coming up reactive and then reverting back to non-reactive. The qualitative RNA testing doing the same. The viral load first noted to be 6.1 copies per milliliter. So diagnosis here can be tricky. And so you have to be very careful about interpretation of these testing results if you have a patient who is receiving this medication. So after that, if there are any questions, I would be happy to take those.
Thank you, Dr. Nasadi, for this interesting, exciting news on update lecture on this long-acting antiretroviral and management of treatment failure. In fact, there are 2 questions on the Q&A. Can you see them, or shall I read it for you?
Let's see if, yes, I can see them. Okay, so the first question being, how often do you administer Cabenuva? So that depends on the dosing frequency that you are using. So if you're using the Q8-week Cabenuva, which is 600 and 900 milligrams of CAB-RPV respectively, the dosing interval that was approved is every 2 months based on the calendar date. So if you are receiving the injection of the first of the month, then you would receive it always on the first of the month, every other month. The injection schedule that we follow, because of the way the medication was studied, is an 8-week dosing interval. And so I've seen it done both ways. And then same applies for the lower dose, the 400 and 600 milligram CAB-RPV. And so that's either given monthly or every 4 weeks, depending on which schedule your institution decides to follow. And then if the half-life is cabotegravir is a max of 12 weeks, why is the dosing schedule 1 month? So that is based on the pharmacokinetic data that was completed during these studies. They found that that dosing interval left them with drug levels that were consistently above the levels needed to keep the virus suppressed. It does give us a little more flexibility as well if patients are to miss a dose. But anything beyond that 1 month or 2 month dosing interval, depending on, you know, which dosing and scheduling you're following, can result in levels that dip below what's needed to keep the virus suppressed, and patients do become at risk for developing treatment resistance. And then let's see, do the long-acting ART, are they an option for newly diagnosed RVI patients? I apologize, I'm not familiar with that abbreviation, RVI.
It means retroviral infected patients, RVI.
Oh, okay, okay. Thank you. So right now, the answer is no, because of the, the levels that were consistently above the levels needed to keep the virus suppressed, and patients do become at risk for developing treatment resistance. So way the studies were designed, again, that they were only completed in patients who were first suppressed and maintained on an oral antiretroviral therapy. There have been some smaller studies that have been completed on patients who have failed treatment with oral medication and are currently failing when they switch, and so they do have a detectable viral load at the time of switch. I think at some point, you could consider it. But if a patient were newly diagnosed and capable of taking oral medication, I would opt to do that for at least a month or two to hopefully get them suppressed, but at the very least drive the viral load down as much as possible because of the risk of treatment failure if we're initiating this regimen at a very high viral load. Let's see. And then why do we continue PEP for many months despite having the opportunity to tell the patients about the risk of acquiring infection? I guess I don't fully understand the question, but in general, if patients are at risk for acquiring an HIV infection, we want them to have access to preventative medications to, prevent that possible infection. We can't expect our patients to change their lifestyle or their behaviors. And so I think making sure that they're protected is the most important thing. And then also in the setting where we have patients who are partners, so in a monogamous relationship for someone with an undetectable viral load, even in those patients, although educating them on the evidence behind U equals U, I always offer those patients PrEP. Because I think that peace of mind is important. And also, that's a lot of faith that you're putting in your partner to take their medicine every day. And so patients should have that power to be responsible for their own prevention and not rely solely on someone else taking, their pill every day. And then finally, can you compare the viral fitness between wild type and resistant virus? So the wild type virus does have much better fitness than most of the resistant virus mutations that we see. And that's why when you have a patient who is not being exposed to medication, you'll find that the virus tends to revert back to wild type and that we may not see those resistance mutations being expressed. There are a couple of exceptions to that. So for example, like the K103N mutation that we see with non-nuke resistance, or the M184V mutation, tend to not impact the fitness of the virus very much. And so you're more likely to continue to see those expressed even if they haven't been pressured by those medications in some time.
So Natalie, if I may add to the question that was asked, the one that asked, do long-acting therapy on for newly diagnosed HIV patients. I have seen one of the, can you hear me?
I'm sorry, I think my audio is not great. Could you repeat that question one more time?
Question that was asked, the second question on long-acting ARVs for newly diagnosed HIV patients. In addition to, if I may add to your
Oh, yes, please do.
Okay. So I have seen one of the articles that were published supporting this use of long-acting ARVs is flare. Have you seen the flare study? It included newly diagnosed RV patients. But it compared long-acting with cabotegravir. It was found that it was non-inferior to BTG, 3TC, and abacavir, but all of the patients were started for the first 6 months. They were initiated with this BTG, abacavir, and 3TC for 6 months, and after virological suppression, meaning viral load of less than 50, the patients on the long-acting arm were initiated on this treatment, long-acting cabotegravir. This is just to add to support your evidence. There is maybe if there was one question on the chat group. Can we tell us this part of the talk can we, use this medications in the setting where there is no resistance testing? I think that's the question.
Yeah, so I tried to outline options in both scenarios where you would have resistance testing available and also where it may not be available. And so going back to the slides, in each section where we outlined the scenario, like the background regimen when that resistance testing developed, there are options that you could comfortably do even in the absence of resistance testing. So for example, we had a scenario of integrase resistance, or I'm sorry, a patient who developed resistance on an integrase-based regimen with dolutegravir plus a background in RTI. So even in the absence of resistance testing, you could comfortably switch that patient to, for example, a protease inhibitor-based regimen. So you have a new kind of anchor drug and the protease inhibitor, and then it was unlikely that you would develop resistance to both NRTI components. And so you could safely have that background of a tenofovir combined with, an emtricitabine or lamivudine regimen.
Maybe one other discussion point can be, okay. I think we shall end the questions, and Dr. Mihadi will continue to the next presentation, which is on infective endocarditis.
Okay, perfect. We will switch.
Thank you.
Alrighty, can everybody hear me okay?
Yes, we can hear you, sir.
All right, thank you. Okay, hello, I'm Maddie Sabani, and I'm going to talk about endocarditis and cardiovascular infections. One of the things I always like to do is just kind of bring it back to a case. So we have a 35-year-old male who has a history of polysubstance abuse with fever, chills, and myalgias for 5 days. You note that he's febrile at 103 degrees with a white count of 20,000, and they have MRSA bacteremia. So a couple of things that we always ask our patients is, what is their epidemiology history in terms of injection drug use? And just to kind of piggyback off of Dr. Nielsen's lecture, one of the things we always ask, and is specifically for patients who inject drugs, is do we screen them for hepatitis as well as HIV, and then also see if they're candidates for HIV PrEP. And so one of the things we always have to look at is their physical exam findings. So really you're worried about looking for vascular phenomena in terms of HIV, in terms of endocarditis. So do they have anything like septic pulmonary infarcts, intracranial hemorrhages, conjunctival hemorrhages, or Janeway lesions? You look for immunologic phenomena such as Osler nodes and Roth spots. And then the other thing you're going to always look for is, are they complaining of pain anywhere? So anytime there's pain plus bacteremia, it usually means that that joint is infected. I always tell our fellows and trainees to make sure the patient sits up, that you palpate the spine, you press on some joints, and then you always want to have them lift their leg to the chin to see if they have a psoas sign. So here's some examples of conjunctival hemorrhages along with Osler nodes and Janeway lesions. The important thing to realize with the Osler node is that it's painful, and the Janeway lesion isn't that painful. So as you're going through, you notice that the patient on physical exam has a 2 out of 6 holosystolic murmur. You don't notice any Janeway lesions or Osler nodes or splinter hemorrhages, and they do have a left upper quadrant abdominal pain with no back or joint pain. And so the question that you have to ask yourself is, should I be worried about endocarditis? So here's where we kind of segue into the Duke's criteria. So this was updated in 2023 for 2023 was updated, and I'm going to share the differences from 2015 to 2023. So, there's major criteria, and so and there's minor criteria. So the definition of definite endocarditis is that there's a pathologic criteria. So patient goes, they do a valve surgery, the valve shows that there's endocarditis. The second one is when you go through the Duke's criteria. So you have these major and minor criteria. So there's two major criteria. If you hit two major criteria, you have endocarditis. If you have one major and three minor criteria, that's endocarditis, or five minor criteria. A lot of times I feel like we're in this gray zone of possible endocarditis with one major and one minor, or three minor criteria. So let's talk about these criteria. Your major criteria are positive blood cultures with specific pathogens, and we'll get into that, as well as lab tests that could be significant for endocarditis pathogen-wise. And then you have imaging criteria as well. The ones in red highlight kind of what's new in imaging criteria. So cardiac CT has made its way into the guidelines that if your cardiac CT indicates evidence of endocarditis, as well as a PET scan indicating if the valve were to light up on PET scan that they have endocarditis, and then also if their patient undergoes surgery and found to have endocarditis. Kind of looking at what the blood cultures should be, the guidelines break it up into now. What is typical and what is atypical? What is typical and what can be found if somebody has a prosthetic valve or has an intracardiac prosthetic material? One of the things that kind of highlights for me that is new, well, of course, everything in red is new, but pneumococcus and streptococcus pyogenes are now not considered to be typical pathogens to cause endocarditis. Which is interesting because we know that there's Austrian's triad, and Austrian's triad is synonymous with pneumococcal endocarditis in the setting of meningitis and another site of infection. And then if somebody has a prosthetic material or prosthetic valve, think of coag-negative staph, Corynebacterium species, some of your gram-negatives like Serratia, Pseudomonas, Cutibacterium, and now your non-tuberculous Mycobacterium and Candida. What are some of the positive lab tests? Well, there's a test where if you get the valve and you stain it for a specific PCR, such as Coxiella, Bartonella, or T. Whippleyi, those could potentially be diagnostic for endocarditis. Then, of course, we always worry about Q fever with our patients. Bartonella is also another one as well that we look at for serologies. And the ones in reds are the ones that are new from the guidelines. Imaging is very important to do, so you always want to take a look and see what the imaging results show. So echo is true. And what does your echo show? Does it show pseudoaneurysm? Does it show valve regurgitation? Is there partial dehiscence on the prosthetic valve? But the new one that has come out recently has been a PET scan. So sometimes not everybody can get a transesophageal echo, or sometimes there's a case where a patient may have fevers and has a vegetation on the heart valve, and you can't really tell definitively whether or not this is endocarditis or not. So the PET scan is something that could help you out determining whether or not it's infected or not. Going to the minor criteria, so predisposition is one of them. So any history of a prosthetic valve, previous valve repair, congenital heart disease, any mild regurgitation or stenosis of any etiology, if they have a history of hypertrophic obstructive cardiomyopathy, injection drug use, are all considered predispositions for development of endocarditis. Previous history of infective endocarditis, as well as placement of a CIED, are two new ones that have been added to the current guidelines. So if someone has a history of endocarditis, or if somebody has a CID, then those are the patients who would, has a risk or has a minor criteria for endocarditis. Again, we talked about vascular phenomenon, so arterial emboli, septic pulmonary emboli, mycotic aneurysms, intracranial hemorrhages, conjunctival hemorrhages, and Janeway lesions. These are all examples of septic emboli. So, or in terms of your vascular phenomenon, so think of you have the showering of this vegetation from the heart valve that's going to different places, and that's how you wind up with the vascular phenomenon. Immunologic criteria is an immune-mediated complex which occurs. This is how you have osseolar nodes that are positive, having new positive rheumatoid factor, Roth spots. Those are the ones that you have to worry about for immunologic phenomenon. Glomerulonephritis, so if you see hematuria in the urine, that's something you'd have to worry about as well. And then lastly, the microbiologic evidence falling short of a major criteria. So these may be patients that have a bacteria that wasn't in the major criteria that are now in the minor criteria. And so I just want to kind of talk, these are the old Duke's criteria as well. So really what's significant, if you look at this patient's history, they have a high, they have an increased risk with the IV drug use. So that should be one major criteria, one minor criteria. Fever is one minor criteria, and now they have a holosystolic murmur. So that's 3 minor criteria with blood cultures with MRSA. So this patient has a diagnosis of endocarditis. Now, so you should be worried about endocarditis, and now you want to have to do a TTE. So we always ask ourselves, TTE or not TEE? That is the question. And really depends on what your clinical index of suspicion is in terms of a transthoracic echo. So for a transthoracic echo, these are patients that it will be the first echocardiogram that you do. And if you see that there's not evidence of endocarditis present, you may just want to go to the transesophageal echo. You will see it in textbooks. It will be written as TEE or TOE in terms of transesophageal echo. So if there's any concern for transthoracic echo, you should always do the echocardiogram. The transesophageal echo is more sensitive in detecting vegetation and abscesses, especially for patients that might be a little bit more barrel chested. The other thing too is that if you get an echocardiogram and there's no evidence of endocarditis, it's usually good to repeat the echo in 7 to 10 days. And the reason why is because it actually takes time. Again, this is an ultrasound. So it's going to take time for some of those visual aspects or visual changes to occur on the echocardiogram. And usually when patients take care of, are usually treated for endocarditis, we always get a repeat echo to establish a new baseline for the valve function and morphology. So some of the exams that were concerning here is that the patient has abdominal pain. And so anytime, remember we talked about the vascular phenomenon. So the vascular phenomenon is the showering of emboli to different places. And you always worry about innumerable splenic, you always worry about splenic infarcts or abscesses. These are usually things you can watch, but if they get worse and worse, sometimes these patients have to have a splenectomy. So one of the things you have to always ask yourself is, well, I have this patient currently on vancomycin. Am I happy with this antibiotic regimen, or does the patient need surgery? And when you approach a patient with endocarditis, there's 2 questions you should always ask yourself. Is this a native valve endocarditis or prosthetic valve endocarditis? And what is the pathogen? So let's talk about Staphylococcus aureus. So, we have methicillin susceptible or oxacillin susceptible, and we have oxacillin or methicillin resistant. So for native valve endocarditis, we tend to use either napsillin or oxacillin. And then for those who have penicillin allergies, we'll use cefazolin. You have oxacillin resistant strains such as vancomycin or daptomycin, what you would use in the other ones. I will tell you that this is more of a preference in terms of who uses what antibiotics. They're early on when these anti-staphylococcal beta-lactams came out, there was a question on whether or not oxacillin had better, killing action versus cefazolin. And so some people would actually prefer to use oxacillin, nafcillin, or methicillin because of a phenomenon known as the inoculum effect. I think as time has gone by, there's been a divergence in that theory. Me personally, I'll use cefazolin or in cases of just pure endocarditis. If I need anything with CNS penetration, I'll usually use oxacillin. So again, going back to our case, we said this was MRSA bacteremia with a prosthetic mitral valve endocarditis, correct? And so now the question is, well, how do you treat prosthetic valve endocarditis with MRSA? So you have, if it's methicillin or oxacillin resistant, you're going to use vancomycin plus rifampin plus gentamicin. Now the rifampin should only be started when patients have cleared their bacteremia. The thing we were about rifampin is that it is it's an inducer, so there can be a lot of drug-drug interactions with it. But for oxacillin susceptible, you can use oxacillin, rifampin plus gentamicin, and know that the gentamicin is only for 2 weeks that you're going to give. I think these are guidelines that, anytime you look at guidelines, you have to say, well, what's the clinical evidence behind it? The evidence for rifampin is actually pretty weak. There's low level, there's not a lot of evidence to support the use of it. But we use rifampin because it does have this bactericidal activity against biofilms that are produced on the prosthesis. And so there's a lot of articles that are coming out in terms of whether or not they should use rifampin. So this was a study that was published in CID in, I believe, 2023, which looked at patients who either got rifampin or did not receive rifampin for staphylococcal species. This also included coagulase negative staph. So it was an observational retrospective cohort of all patients with staphylococcal prosthetic valve endocarditis. The primary outcome was 1-year mortality. They had 180 patients that were enrolled. And you can kind of see about only a quarter of them actually wound up getting valve surgery, which for us, that means that they have source control. Despite all of the isolates being susceptible to rifampin, 56% got rifampin, 43.9% did not receive rifampin. And really what they noted that the 1-year mortality was 37.6% and 31.6% in patients treated with or without rifampin. And the relapse rates were similar in both groups. And so when they looked at the conclusion of this study, they saw that 1-year survival and relapse rates were similar in patients treated with or without rifampin. I will say that there was another study that looked at something very similar in 2016, and they saw that there was no difference with utilization of rifampin. So I'll be honest with you, usually when we have patients that need treatment for prosthetic valve endocarditis, we say, okay, they have a lot of drug-drug interactions. They're going to be on Coumadin. So why don't we just withhold the rifampin? And then for the aminoglycoside, which is something that there's more and more evidence showing that maybe it's not needed. We'll say, well, they're already in acute kidney injury and we don't really want to harm their kidneys. So I have seen a lot of monotherapy that's gone through. I'm going to take a little bit of a sidetrack here because I really do like the concept of persistent MRSA bacteremia. And so in these cases here, one of the indications for surgery is when patients have persistent bacteremia in the setting of appropriate antibiotic therapy. And so, usually the question is, well, if they're still persistent, what are you supposed to do? And really, this is a case here where I always like to talk about the Camera 1 and Camera 2 trials. So I apologize for deviating a little bit. But, Camera 1 initially looked at patients with MRSA bacteremia and whether or not there's a synergistic approach with beta-lactams. So in the phase 2 trial, there was 60 patients, 29 got vancomycin and 31 got vancomycin plus flucloxacillin. And they saw that the mean duration of bacteremia was 3 days versus 1.94 days. The p-value was not statistically significant, though. There was no difference in 28 or 90-day mortality, metastatic infection, nephrotoxicity, or hepatotoxicity. So this led to the Camera 2 trial. And what they did is that they said, okay, we're going to obviously broaden, recruit more people. And what they saw was that they had to terminate the study early because the patients in the beta-lactam plus standard of care therapy group actually developed acute kidney injury more than standard of therapy alone. And so that's why this trial was terminated. So this has brought initiation to daptomycin and ceftaroline combination therapy, where daptomycin has a tail which binds to the calcium channel on the cell wall of MRSA, and ceftaroline also has direct mechanism of action to treatment of MRSA. And what they did, they actually had this was a randomized control trial where they looked at daptomycin and ceftaroline versus standard of care with vancomycin. And they actually saw that there was an increased mortality for the monotherapy group, so they halted the study. So the question always becomes, what's the best way to treat MRSA bacteremia? I would say we really don't know. I would say if I have my practice is if I have a clinical index of suspicion that the patient is going to have high-grade bacteremia, I just start them off on daptomycin and ceftaroline, and I start them on ceftaroline, and I will just de-escalate later. So after you have the patient finally clears their bacteremia, you give daptomycin and ceftaroline. They take the patient to the OR. They replace the mitral valve versus repair the mitral valve. The question always becomes, well, do you have to continue combination therapy, or can you de-escalate? So this was a question that we actually asked ourselves here at Ohio State, and we actually found that there was no clinical difference whether you de-escalated from daptomycin, ceftaroline to daptomycin, ceftaroline, or vancomycin alone. So sorry for the little veer off here, but it's very a lot of this data is always changing, but I guess I could say Staph aureus bacteremia is really bad, and sometimes these patients are very difficult to treat. Let's talk about some of the other bacteria that can treat endocarditis. Sorry, some of the other bacteria that can cause endocarditis, specifically with Enterococcus, Hayseck, and Streptococcus. The MICs are going to be very important when you're looking at Streptococcus bovis. I won't read the tables out here. I know you guys will have my slides, but you can see that there's based on the MIC to the penicillin, you can do either penicillin or ceftriaxone. If you want to reduce the duration of therapy, there's some evidence that you could just do 2 weeks of ceftriaxone plus gentamicin instead. Then if you have a resistant Viridans group strep or Streptococcus gallidicus, or formerly known as bovis, these are patients that you want to actually give penicillin G plus gentamicin to, or you want to just give them vancomycin. And if there's a prosthetic valve, you always are going to look at the penicillin susceptibility, but really there's no difference in terms of the gentamicin utilization or the or vancomycin. Now with native valve endocarditis with Staphylococcus, we don't really have to worry about the addition of rifampin or gentamicin. Like I said, the rifampin is really just there for the treatment of the biofilm. And the gentamicin, the data comes back from the 80s, where essentially they noticed that when vancomycin works on the cell wall, it causes the cell wall of MRSA to break up, allowing for gentamicin to enter the MRSA bacteria and work on the ribosomal subunits. Now, whether or not that has held the test of time has remained to be seen. In the past, we used to treat patients with MRSA bacteremia with vancomycin and gentamicin. But we stopped doing that because although there was a decrease in days of bacteremia, there was no difference in mortality. And again, this is just repeating the previous slide as well with the rifampin and the gentamicin. The last one I want to talk about is Enterococcus. So Enterococcus is different in the treatment compared to, well, the presentation is different than the presentation of Staphylococcus. So think of Enterococcus and your Streptococcus bacteria as bacteria that's very, very indolent. So these patients will be sick for a while. They'll be sick for some time. And, they may show up to your office and just complain of fevers, having the dwindles, not being themselves. And you will check blood cultures on them and they will be positive for Enterococcus. We don't have a lot of great antibiotics for Enterococcus because the vast majority of them are bacteriostatic. So we have to add an additional agent with gentamicin. So if you recall, gentamicin has a couple of adverse effects, right? It can cause nephrotoxicity, it can cause ototoxicity, and 4 to 6 weeks of gentamicin could be difficult. The antibiotics that we use to treat Enterococcus is penicillin, IV penicillin, IV ampicillin, IV vancomycin, IV daptomycin, and then linezolid. But again, linezolid has a lot of toxicities as well. So one of the things that actually recently, maybe about 10 years ago, came out in literature is there was a group in Spain that looked at ampicillin plus gentamicin versus ampicillin plus ceftriaxone. Ceftriaxone does not have any activity against Enterococcus, but what it does is it binds the penicillin binding proteins that ampicillin would otherwise bind to, but it does not bind to the penicillin binding proteins that ampicillin actually will work on for against Enterococcus. So it allows for more binding sites for the ampicillin. And they saw that there was actually no difference in mortality in this patient population. Now, let's say you have a patient that have penicillin susceptible native or prosthetic valve endocarditis. Oh, and Enterococcus is the one that does not have a difference in terms of treatment between the two groups in terms of a prosthetic valve or native valve. But in this case, you can give streptomycin. But I would say with the addition of ceftriaxone, this is not something we really do. And then, of course, you can always use vancomycin. I would say I don't think a lot of people use vanc and an aminoglycoside. It would just be very, very difficult for patients to tolerate. And then lastly would be linezolid or daptomycin. This is the observational trial. I won't go through it, but this is what I was talking about that came about 10 years ago. And so, they saw that their patients actually did fine in the AMP ceftriaxone group. When they had this commentary, they said, is it time to abandon the aminoglycosides? One doctor said they're going to continue with the aminoglycosides. One of them said they're going to adopt the thing, and the other one was indifferent. So I would say a lot of us have gone to the ampicillin ceftriaxone. Some of us are purists, though, and still like the aminoglycosides. And then for Hayseck organisms, it's either ceftriaxone, ampicillin, or ciprofloxacin. Doesn't matter if it's prosthetic valve or native valve. The guidelines are vague in terms of what to do with non-Hayseck gram negatives. So the guidelines would say, well, you do have to use 2 antibiotics to treat, maybe a beta-lactam plus aminoglycoside or fluoroquinolone. We actually looked at this here at Ohio State as well, and we found over a 10-year time period, there were about 60 total encounters. 34 patients had only 1 antibiotic, so like a beta-lactam, versus 26 of them actually had combination therapy. And we saw that there was no difference in our 60-day bacteremia recurrence, readmission, or mortality among patients treated with combo or monotherapy. I will say that the Pseudomonas group were patients that tended to have a lot higher morbidity and mortality. And so this was just something that we had noted here. So I would say it depends on how your patient looks. If your patient is difficult to clear, has Pseudomonas, cannot get surgery to repair the heart valve, then those may be patients that you do combination therapy on. A lot of the antibiotics I talked about are IV antibiotic therapy, but what about orals? I will say that MRSA bacteremia is really bad. I've seen a lot of failure on oral therapy with Enterococcus. So this was a study published in 2019 called the POET trial, or partial oral versus IV antibiotic treatment of endocarditis. There were 400 patients with left-sided endocarditis. Here are the pathogens listed. 199 received IV throughout their course. 201 patients actually got oral therapy, were switched to oral therapy 10 days after receiving IV. And what their primary outcome was a composite outcome of all-cause mortality, unplanned cardiac surgery, embolic events, and relapse of bacteremia from the time of randomization until 6 months after the treatment was completed. And what they saw is that the majority of these patients Saw no difference between oral versus IV antibiotic therapy. But I would say a couple caveats with this. One, these were patients that were pretty stable, cleared very quickly, did not require ICU care, and majority were left-sided endocarditis, which left-sided endocarditis still continues to be one of the more serious forms of endocarditis compared to right-sided endocarditis, which is seen with a lot of injection drug use. But the other thing too, it did not really have MRSA. And the pathogens primarily were Streptococcus, which we know that Streptococcus can actually be treated with an oral fluoroquinolone like levofloxacin. And so levofloxacin has good bioavailability, and so it remains to be. I mean, you could conclude that the Streptococcus would actually be very good. There was a low number of patients with prosthetic valve endocarditis. Only 13 patients with Staphylococcus aureus, all of them MSSA, 7 of them got oral. So we'll see where this leads us, but it is good to see that there are studies being done to look at this. I'm not going to read all of this because one, I think I'm short on time, but two, just kind of what the indications for surgery are. So what I would say is that if the valve is destroyed or there's a vegetation greater than 10 millimeters, these are the patients that would benefit from early valve surgery in left-sided and native valve endocarditis. Prosthetic valve endocarditis is a little bit more trickier, but the same would apply. The reason why the same criteria apply for when you want to do surgery. The issue with prosthetic valve endocarditis is that think of that patients have so much real estate to take out the old valve and put a new valve in. So you want to make sure the surgeon wants to make sure that the sutures go in correctly. They want to make sure that the valve holds still. There's not a lot of necrotic material around it, so it can be difficult. The other thing too is that fungal endocarditis is something that definitely needs surgery. Fungal endocarditis like Candida or our patients who inject drugs, it can be very difficult to treat, and they have to be on oral azoles for lifelong. So we have issues. It's kind of tough for us to care for those patients. Right-sided endocarditis would actually tell you that you need actually larger vegetation, and they would actually recommend to repair the valve, not so much replace it. I also want to include the European guidelines as well in terms of what we have seen, what they have for surgery. And I've included this in the slide, but it's very similar to the US guidelines. You know, for us here in Columbus, we've seen a lot of injection drug use here. And so we are seeing a lot more patients with injection drug use endocarditis. So we do see a lot of our patients developing this. I'm going to skip over the ICD infections here, and you can look at that later. But my parting thoughts would be is that Staph aureus bacterium is bad. Make sure you can identify whether or not it's a native valve versus prosthetic valve endocarditis. In certain situation, oral therapy may be acceptable. But again, you really do have to kind of look at the patient and see what is the best decision for them. So thank you for listening to my talk. I'll take any questions that have come up.
Thank you, Dr. Mahdi, for your excellent lecture on infective endocarditis. I think I can't see any questions on the Q&A or the chat. Maybe few discussion points that you can elaborate. As, maybe there are some, in resource limited settings, usually there can be culture negative endocarditis, or usually the treatment will be empirical treatment. So what's your recommendation on empirical treatment of infected endocarditis? Maybe the other questions can be, there can be another limitation is also, doing surgical interventions can be difficult in low resource settings. So what's your experience in the treatment of fungal endocarditis with medical treatment? So if you can reflect on these 2 points.
So I heard the second question. So the one was the management of the fungal endocarditis and what we've seen.
Yes, maybe medical management, since surgical intervention can be difficult in low resource settings. medical experience, your experience on medical management of fungal endocarditis, and maybe empiric approach of treatment, since most of the treatments can be culture negative, or maybe if there is no growth, what's your recommendation on empirical management of infected endocarditis?
Yeah, what we'll do is we'll I mean, we'll give them we'll treat our patients with, for fungal endocarditis in particular, it depends on what the fungus is, but these patients tend to be on lifelong oral therapy if need be, like fluconazole. One of the things that we worry about in particular is the drug-drug interactions with the fluconazole or the azoles. In addition, it can have some prolonging of the QT. It is difficult to whenever a patient does have fungal endocarditis. From my experience here, it's been a lot of patients who have injection drug use, and so those are patients that really we have to treat the underlying etiology for why they're having endocarditis, which is the injection drug use, so Suboxone therapy, things of that nature. But the vast majority of these patients will need antifungal therapy for lifelong. I have seen patients break through on antifungal therapy depending on what the fungus is. But yeah.
Thank you. So there are a few questions on the Q&A. Can you see them, or shall I read it for you?
I can get it here. It says, I guess the first question is, place of reperfusion therapies for vegetation emboli to coronary arteries. I don't believe that the coronary arteries get vegetations. Usually it's a different mechanism. I will say that a lot of the times, the reason why patients are placed on ECMO here is because they just have really bad heart failure as a result of their endocarditis. So yes. The place of anticoagulation for septic emboli, that's a good question. There's no evidence to support utilization of anticoagulation for septic emboli. The thing is these patients actually, they will wind up cavitating and going into worsening respiratory failure as a result. And so we really do have to just let the patients and the doctors taking care of the patients know that this is more of a destruction issue and not an antibiotic issue. And actually, sometimes they have to go and depending on how bad the infection is, clean out the lung. What do you recommend in patients who grow resistant Staph aureus and consider oral therapy since So oral vancomycin is not recommended for treatment of MRSA bacteremia. It's a low dose and it's only in the goes into the gut. One of the things I would say is that the treatment of MRSA endocarditis you could potentially use as high dose, or you could use linezolid in those patients. But again, linezolid has a lot of side effects like neurotoxicity, can cause bone marrow suppression. Some anecdotal stuff has had oral trimethoprim sulfa at a high dose, but really the standard is using really the standard is IV antibiotic therapy, but oral linezolid would be something to consider, or high dose oral trimethoprim sulfa. If a patient is persistently bacteremic, I don't believe any of those are going to be beneficial for them. What is the ideal time interval between an embolic event and surgery for infective endocarditis? It depends on what the embolic event is. So if the embolic event is to the brain, the things that we'll look at is how big of a CNS catastrophe it is, and And so is it a large CNS catastrophe? Is it just minor strokes? Is it a minimal neurologic deficit? And then when can they actually place the patient on heparin? So when they do the valve replacements, when they do the valve replacement surgery, and after the patient has their valve replaced, they're actually put on blood thinners. And so what you worry about is this evolution of a thrombotic to hemorrhagic stroke conversion. So those are the things that are worried about. It really depends on how bad it is. I've seen them wait anywhere from 7 days to after completion of antibiotic therapy. Where are we in the development of vaccine against rheumatic fever, which can be a risk for infective endocarditis? That one I'm not really sure, to be honest with you. The development of vaccine against rheumatic fever. I don't think the vaccine. Rheumatic fever is definitely a risk for development of infective endocarditis, but I don't think the vaccine would be something that would cause infective endocarditis if they were going to make a mechanism for that. So. Question is choice of PO antibiotics for treatment of infective endocarditis. So I would say right now it's still IV antibiotic therapy. Again, the only clinical trial that's come out was that New England Journal of Medicine clinical trial called the POET trial. And that was the one which looked at, doing IV and then switching to oral. In that supplement over there, they had every antibiotic listed from Levaquin to linezolid. But again, it depends on the patient, the degree of bacteremia, the degree of infection. I would say personally, I'm not sold that there's an oral regimen for the treatment of MRSA or MSSA bacteremia. But that paper was a pretty good paper to look at in terms of what the majority of the pathogens were, and the majority were streptococcal species. So.
Great, thank you. I don't think I see any more questions. So I can go ahead and I think close out the session again. Thank you to
Dr. Shu?
everyone who's
Sorry, Dr. Shu. I think Dr. Getachew has a question. Dr.
I'm
Getachew.
so sorry. Okay, go ahead, sir.
You can unmute Dr. Getachew. Okay. Dr. Getachew, do you still have a question? Okay.
Well, feel to email me if you guys have any questions, or if I was unable to answer your questions. It's a lot of material, so thank you.
Great. Thank you. Yes. So the session has been recorded. It will be shared with everyone, including the recording as well as the PowerPoint slides, and also a certificate of attendance. I would like to thank the speakers, Dr. Zainab El-Badagli, Dr. Natalie Nielsen, and Dr. Maddie Subani for the wonderful, enriching, and engaging lectures. I would also like to thank my co-moderator, Dr. Hiwat Bayene. Thank you. And I would like to thank Dr. Kibru from OSU Gohai LLC for all the organization that he has done, as well as Mr. Ashetu for the IT support. Thank you again, everyone, for the wonderful session. We look forward to hearing from you and look forward to next year's session. Please submit any comments or any questions to us, or any topics you would like to hear for next year. There is entire series of internal medicine lectures that are in the next 2 weeks. So please go on to our website and enroll and register for the other sessions. Thanks again.
Please don't forget to fill out the forms for Dr. Natalie.